This video will cover the approach to shock, focusing on recognition, pathophysiology, and management. The information presented is referenced from Tintinelli's Emergency Medicine, 8th edition. Shock is defined as a state of cellular and tissue hypoxia. This is caused by reduced oxygen delivery, increased oxygen consumption, or inadequate oxygen utilization. This condition affects over 1 million patients annually in the U.S. Mortality rates are significant for septic shock, ranging from 40% to 60%, and for cardiogenic shock at 36% to 56%. Hemorrhage is a leading cause of preventable trauma death, making early recognition and intervention critical. Oxygen delivery is the product of cardiac output and arterial oxygen content. Cardiac output depends on heart rate and stroke volume, which are influenced by preload, afterload, and contractility. Organ perfusion fails when the mean arterial pressure drops below autoregulatory levels. The four categories of shock are hypovolemic, which is decreased intravascular volume, cardiogenic or primary pump failure, obstructive, a physical obstruction to flow, and distributive, characterized by a loss of vascular tone. Compensatory mechanisms include the autonomic nervous system, which causes arteriolar vasoconstriction and increases heart rate, and hormonal responses. These actions maintain perfusion to the brain and heart at the expense of other organs. Metabolic consequences include anaerobic metabolism, leading to elevated serum lactate. Lactate levels over 4 mmol/L correlate with increased mortality, creating a vicious cycle where lactic acidosis worsens hypotension. Clinical recognition involves checking for hypotension, though not all patients are initially hypotensive. The shock index, or heart rate divided by systolic BP, is concerning if it is above 0.9. Signs of organ dysfunction include CNS changes, oliguria, and skin changes. The rapid ultrasound in shock, or rush exam, is a key diagnostic adjunct. It evaluates the pump for contractility, the tank for volume, and the pipes for vascular issues like aneurysms or DVT. Management follows the ABCDEs. Airway control is crucial, often via intubation. Breathing is managed by mechanical ventilation to decrease oxygen consumption. Circulation requires securing large-bore IVs and administering an initial fluid bolus. Delivery of O2 involves reducing systemic oxygen consumption. Resuscitation endpoints include clinical goals such as MAP greater than 65 millimeters of mercury and specific urine output targets. Laboratory endpoints involve lactate clearance and normalization of base deficit. Remember, constant reevaluation is mandatory. Time is tissue.